Okay.
Thank you so much, Eric, and thank you to everyone who's here tonight to listen. We were so happy to see that so many people signed up. So, Larry, did you want to say anything? Okay. I'm going to go ahead and share my screen, and hopefully we'll have a presentation come up and go ahead into slideshow mode. And okay, hopefully you can all see my screen.
Can everybody see it?
Eric, there's a picture there, right?
Yep, I can see it. And real quick, I forgot to say something. If you guys could please put your full names in the chat so I can mark that you attended. Thank you.
Great. Okay. So this is a talk on head trauma, and it's an area where we know that a lot of people have concerns. Neurological and neurosurgical issues can be complicated. I want to make this presentation not complicated and give you pearls that you can take with you into your practice as a patroller, as an EMT. My background, I am a longstanding advanced practice nurse. My entire career, which is now over 40 years, has been in the world of emergency and trauma care. I'm currently the state chair of trauma quality for Delaware and an NREMT. Larry?
I've got 46 years of ski patrolling EMT background. We're both active in the Wilderness Medical Society as fellows of the Academy of Wilderness Medicine, and these are just areas that we really love talking about.
And I failed to mention that Larry got me into ski patrol through our wedding vows back, well, for me, it was 35 years ago. This is my 36th season. We both patrol at Blue Mountain.
And for the EMTs out there, we met in the back of an ambulance, if that counts.
But I was a crew member, so don't get any other ideas. Anyway, just to get right to it here, let me see how I can advance my slide. For some reason, my slide is not advancing. Okay, there we go. We have no financial disclosures relevant to this presentation. Larry and I are both volunteers presenting this. So we're doing this because we have fun and we enjoy teaching. Okay.
We're going to start off with a case scenario. Now, we're not going to discuss this in detail. We will talk about this case a little later in the presentation. But if you were anything like us as a ski patroller, EMT, paramedic, nurse, physician, if something happens in your neighborhood, do your neighbors call 911? No, they probably call you. So this case scenario, you are off duty. You're at home, you're relaxing, and your neighbor calls. She was mountain biking with her husband. She tells you that her husband fell hard on a paved trail and hit his head. He now has a bad headache. He feels nauseated. She wants you to come over rather than call 911 and tells you that he's refusing to go to the ER or to urgent care. So just keep that in the back of your mind as we go through the presentation.
So there's a lot of common scenarios that involve head trauma, and you can see some of those here. Sports injuries, falls, certainly snow sports, especially with a lot of the people who take great air off of features and terrain parks, but also just collisions with man-made as well as natural objects at ski areas, motor vehicle crashes. So any of these types of incidents can result ultimately in a head injury, and we know that. Trying to get my slide to advance. Okay. Well, what I would like to do first is just give you a brief anatomy review. But don't worry, this is not going to be something where you're kind of struggling through all the typical, neuro stuff. I want to talk about functional anatomy, the things that you're going to take with you that are going to help you in your practice immediately. So, for example, here we have a diagram of the skull and a picture of a skull. So clearly the purpose of the skull is to protect the brain. And, we obviously cannot see inside the skull, but we can assess the patient and get clues that there may be something going on. I want to point out a few things that you may or may not know. So first of all, in terms of the skull, the frontal portion of the skull is overlying the cerebrum, okay? You take a good hit to the front of your head and you have an underlying brain injury to that frontal region, what you're going to see is potentially an agitated individual who does not conform to social norms. Let me just put it that way. So this is a person who may be acting out, aggressive. You're thinking, oh, the person's intoxicated. I mean, they may be. However, frontal brain injuries actually come with some very combative types of behavior. So all behavior has meaning in head injury. Another important area is the temporal bone. Okay, it's right here. Okay, so the temporal bone is the thinnest bone in your skull, and a hit to this area of your skull can have some pretty big complications, such as a skull fracture here overlying the middle meningeal artery can produce an epidural bleed. And I'm going to go into some epidural bleeds in detail soon. But for now, just recognize that this is thin and it is very prone to injury and to fracture and to causing a head bleed when you're assessing a patient. The occipital area of the skull is the area that most importantly, it has two major functions here. So within this area is the cerebellum, and I've got a picture of that coming up. Cerebellum is really your balance center, your coordination, gait, all of that. So a hit to that area can produce changes in balance, feelings of dizziness, but also it is the visual cortex. So if you take a hit to the back of your head, these are the people who have concussions that talk about seeing stars. Okay, they actually may. They may actually have a period of blindness. But interestingly, if you were to assess them and look at their pupils with a pen light, you will still get a pupillary response. So it's not a matter of them not being able to see with their eyes. It's a matter of them not being able to have their brain interpret the visual image. And then, of course, the parietal skull mostly is overlying other parts of your cerebrum.
Something to keep in mind here too, we don't have a real good picture of it, but if you looked inside the skull, it is not a nice, smooth structure. It is full of little bony protuberances. So keep that in mind when you're talking about the potential for brain injuries and high impact, high velocity impacts.
One other thing is as far as your face goes, your face is made up of the zygoma, your cheekbones, the orbits, obviously the maxilla and the mandible, nasal bone, all of that. Sort of behind, or I think of your function of your face in some ways is like the airbag for your brain. You've got these air-filled sinuses. So we have had patients who've taken some pretty considerable hits in the face. And literally, they've had minimal brain injury as a result of that airbag effect of sinuses. And we can talk more about that. But these folks are also at risk of a particular type of skull fracture called a basilar skull fracture. And we'll go from there. So overlying the brain itself, okay, below the skull, are the meninges. And the meninges are the coverings of the brain. And these are important to know from the standpoint of understanding the different head bleeds that patients can have and how they manifest. So the dura mater is the tough outermost double layer of connective tissue that covers the brain itself. So the dura mater is actually two layers, and those two layers are firmly adherent. One of the layers forms the periosteum of the skull. So if you were to take the skull off and you're to look inside the skull, one of those layers of dura would actually be covering the bony part of the skull itself. And if you peeled that back, you'd actually have a second layer of dura that covers the outer part of the brain. The arachnoid membrane is basically, where your cerebrospinal fluid and your vessels are located. And the function of that cerebrospinal fluid is cushioning of the brain. And then you have the pia mater, which is a very delicate tissue, which is covering the brain itself. And it is highly vascular, as I have noted in the slide. And then some other anatomy. This is just an MRI shot of the brain. You can see that the vast majority of brain is made up of the cerebrum, and that's your higher level thinking and your voluntary control and all of that in your body. So pretty critical areas. Remember that frontal part of your brain does control a lot of your emotion and your um, kind of ability to behave yourself in public. Okay, so when people aren't behaving themselves in public and they're acting out, you have to think about a frontal head injury. Other important parts: thalamus, hypothalamus. We're not going to get into that here, except to say that it will regulate, your body temperature, your endocrine functions, and those sorts of parts of the brain that are not under voluntary control. In the hospital, this has a lot of implications for care of the patient, but not so much in the pre-hospital arena. Midbrain pons and medulla make up the brainstem. What is important here is the brainstem is controlling your vital signs, right? So pressure or damage to this area can take out your breathing, can cause your blood pressure to fall or do strange things, right? Heart rate. So you want to be very much aware that a brainstem injury can be a deadly situation. And then, of course, we have the spinal cord. I'm trying to get my pointer to work here, coming right off the brainstem, and it's coming down through this big hole in the bottom of the skull called the foramen magnum. And we'll talk more about that later, but this is just more introducing concepts. And we have the cerebellum, and the cerebellum is, again, your kind of balance, gait, sort of fine, motor control type of center. So moving right along. All right. So there are a lot of head injuries in the United States, in the world, actually, and they're very significant in terms of leading to trauma-related death. So it caused a third of all injury-related deaths. Now, back when I started in trauma care, back in the 1980s, so it's been a long time, I remember seeing in our statistics that motor vehicle crashes were by and large one of the major causes of brain injury. And it's still, motor vehicle crashes still are. However, falls in almost all trauma centers across the US have become the #1 cause of head injuries and, by the way, trauma that is being seen in trauma centers. And that is because of the aging population and the risk of people who are aging to have balance issues and other problems that predispose them to falls
And they're staying more active.
and staying more active.
The younger age group, the 15 to 19-year-olds, the trauma community refers to them as YAMIC. It's the young adult male immortality complex, because nothing can hurt them at that age until it does.
So, if you look at a graph of trauma mechanisms of injury, you will see like a bimodal distribution. You see the highest risk, or excuse me, age group epidemiology, bimodal. You'll see highest risk in that, 15 to 19, and then that second in that age greater than 65.
The mechanism of head injury can be broken into obviously blunt and penetrating trauma. The blunt trauma aspects of mechanism of injury, as Linda said, motor vehicle collisions rank up there. As she also said, falls kind of lead motor vehicle collisions now, for a couple of reasons. One, aging population, more active population, in addition to improved motor vehicle safety. Back in the day when seat belts didn't exist, you had much more significant and much more frequent head injuries and fatalities in motor vehicle crashes. But falls, assault, very popular baseball bat assault, assault with blunt objects, sports injuries, football, soccer, ski injuries, any kind of contact sport, a lot of industrial injuries, and also we have blast forces to consider, both intentional and unintentional.
Okay, so when we think about blunt trauma, yeah, maybe you've seen or heard of the concept of the 3 collisions of blunt trauma in motor vehicle crashes. It's important to think about here. So in a motor vehicle crash, you have the crash of the vehicle and something else, right? Another vehicle, a tree, a guardrail, whatever the vehicle struck. You have the occupant within the vehicle, and that occupant may be seat belted, which hopefully will minimize the damage to the individual. If the person is not belted, then that person may be a flying object within the vehicle. And also you have the person's organs or internal structures within the individual. So when we think about forces that are involved, clearly you have the vehicle, which is taking in some of that impact. However, if that individual is flying around that vehicle unrestrained, then any parts of their body could be traumatized in addition to their head. But we also have to think about the things that we don't always see with our eyes, and that is the parts of our internal structures that are now under those forces. So you may have shearing forces. You may have fixed points of attachment of blood vessels, of ligaments, of any of the internal organs tearing away and actually causing more bleeding. And you can have like getting tongue-tied here, thoracic aortic injury from the aorta literally being ripped off of one of its fixed points of attachment. We don't know that, but we have to suspect that. And the brain itself, since this is a head injury talk, can also move within the skull, right? So when you are young, you have a relatively tight skull, your brain fills your skull. As you age, your brain atrophies. That can be accelerated through drinking some alcoholic beverages, which most of us do enjoy. Those who imbibe too much have a much smaller brain than others because you do actually lose brain cells. So the older you get, you actually have more room in your skull. So your brain can be sloshing around in that skull through these 3 collisions of blunt trauma. As your brain slides one way, you can strike the skull and produce an injury, and we're going to talk more about that. But for right now, this is a discussion point. So what injuries do you suspect if you come into a situation and you're looking inside a motor vehicle and you see this? I need some participation here. So what do y'all think?
Throw some injuries out in the chat or unmute.
The brain, the head and chest hitting the steering wheel or the airbag.
Good.
Okay,
What else?
awesome.
Whiplash from the head snapping back after it's hit the steering wheel.
Okay.
Absolutely.
What else?
Possible leg injuries.
Yes. Yes. And can you tell me why that is? I want to hear this.
Well, you went forward into the dash. You actually moved forward into the dash and possible femurs, etc.
Excellent.
Good.
Excellent. Because as that dashboard is coming in or the patient is going into the dashboard, that knee will strike that dashboard and it actually can push the femur posteriorly back through the acetabulum. And that is where you can get an acetabular fracture or posterior hip dislocation. So excellent.
What's real obvious in the front of the vehicle?
Shattered windshield.
Shattered windshield. So obviously you think what?
Well, you could have flying debris. There could have been something coming through the windshield. There could have been something potentially exiting the windshield.
Potentially.
Looks like it's mostly concaved, but
Mhm.
if the person wasn't wearing their seatbelt and they didn't catch the dash, they could have been
Right. And this vehicle is old enough that it doesn't have airbags, right? So we didn't have those protections either. So
And one thing you don't see in here, but in this type of scenario, you'd want to consider is what about another object or another passenger in the vehicle who may be unrestrained or an object that's not tied down, something else flying around in the car. So it may not just be the driver and the vehicle itself, but other things in the car that may be flying around and creating a great deal of impact.
So thank you so much for those answers. That's great. You guys nailed it. I see some blood on the dash there too.
Mhm.
Looks like right around the glove compartment. So yeah, I'm sure that was in fact that was one of our cases that came in to my trauma center.
Now, next to blunt trauma, we also have to consider penetrating trauma when you're talking about mechanism of head injuries. Today's world, potential for stab wounds, gunshot wounds, shotgun wounds, other projectiles, impaled objects, from sports injuries. We don't see it too often, but ski poles, tree branches, unintentional impaled objects. The picture at the bottom was one of Linda's patients. The take-home lesson here is be careful who your hunting partner is when you're going crossbow hunting. He did survive.
Yes, yes. We got some good pictures out of the deal too. So anyway, as a trauma person, you're kind of into that. But yes, so don't pull out the impaled object either. And that would be tough to pull out. So he did have to go have some surgery to remove it. Okay, so we're going to go over some various types of head injuries. This is just sort of an overview slide right now, and I'm going to go through these in some detail to give folks a sense of what is actually happening within the cranium. Now, I take a little bit of a different approach. A lot of programs will start out with, the anatomy and the assessment. I want to actually show you the injuries. And a lot of the pictures that I have are actually, again, from the trauma center imaging. So I can actually show you what happens when these bleeds occur. And after we go through that, I'm going to talk about a little bit of physiology of intracranial pressure. And then we're going to get into assessment so that you can put all of it together with a visual. I think the visual is key to remembering what is actually going on. So because, we are limited as ski patrol, as EMTs, or as people in the field, right? And if you don't have a CT scan or an MRI, in the next room, we can only kind of get a sense of what might be going on. But in order to definitively identify these types of injuries, most of these injuries, certainly not a scalp laceration, but others, we need some diagnostic studies. So these are the neurodiagnostic studies that when we send a patient in for evaluation in a hospital, they may receive. It's also possible they just may have an assessment by a physician or other advanced practice provider. But certainly CT scan is considered, hallmark in as a standard for identifying types of brain injury. Patients may need magnetic resonance imaging, those who have potential spinal cord injury or those who may have a stroke. And then there's other types as well, angiography, evaluating the vessels and whether the vessels may be disrupted or have an aneurysm, for example, or are clotted off. And a skull series. Now, years ago, before CT scanning, when I first became a nurse, I was a nurse in Baltimore Shock Trauma in Maryland, and we just had a CT scanner. It was sort of a novel thing down there, but we had a lot of people getting skull X-rays, and over the years, the number of skull X-rays have decreased because CT scans are so good that they pretty much have supplanted the need for a CT scan. So we'll start with something pretty basic. The scalp injury. So
Scalp injury is probably one of the more common injuries that we see in the field, whether it's EMS or at the ski area. The scalp has a very rich blood supply. Scalp injuries bleed, and they bleed a lot. It can be very dramatic, even with a relatively minor injury. The challenge is trying to determine whether it's a minor injury beneath that laceration. They can bleed a lot. Basic treatment, dry dressings, layer if the bleeding continues, resist the urge to keep peeking at it to see if the bleeding stops, basic wound care. Consider the risk of possible underlying skull fracture. You may have an open head injury, so you're going to consider the mechanism. Was it a fall from height onto the head? as opposed to maybe just a windmilling ski that, caught them, or some other mechanism that would give you a low incident, incident of considering a possibility of a serious injury. You want firm direct pressure, keeping in mind that if there is an underlying skull fracture, if you feel bogginess, if you feel crepitus, be very gentle with that firm direct pressure, because if there is an underlying skull fracture, you don't want to press those bone fragments down.
Usually in the hospital, they're going to either staple the scalp closed, depending on the location of where that scalp injury occurred. It may be sutured, but oftentimes these are wounds that are stapled. So skull fractures, we'll talk about those next. And I have a great slide. It's literally a 35mm slide, and I ordered a digitizer because I wanted to include that in today's presentation. This was a gentleman who took a ball peen hammer and went whacking himself all over the head. And we had all these little depressed skull fractures, and it would have been a great picture, and you would have had the permanent image in your mind of what a depressed skull fracture looked like, multiple depressed skull fractures. But alas, because of the weather in the South, I didn't get my little slide digitizer, but in the future. So as Larry said, you can have an open skull fracture or you can have a closed skull fracture. Now, a closed just means that there's no external opening, including there's no laceration overlying that skull fracture. You may have some swelling over the area. You may have head pain, or there may be deformity that you can actually feel when you palpate. There are many types of skull fractures. There are linear, which is just kind of a straight line fracture. May not be a big deal. I mean, we don't cast someone's head, but where it becomes a bigger deal is if that skull fracture is overlying that temporal bone, that thin bone in the skull, because of the middle meningeal artery that lies below it. And it's the linear skull fracture over that temporal area that produces the epidural hematomas by and large. So you can keep that in mind. Depressed, you can typically feel, and the neurosurgeon may need to go in and then elevate that depression, and they can do that. Comminuted means that now the bone is not just depressed, but it's also in little pieces. So they've got to go in and debride out, or remove all those pieces of bone, and then they may be putting a plate or close that defect in another way. And basilar, and I want to just mention basilar for a moment. So we're going to talk about basilar in some detail, but I talked about the fact that it's sort of your face is kind of the airbag of your brain. If you were to take your face off, behind your face is the base of your skull. It was kind of wondered where the base of your skull is. So if we look at the base, we can, just imagine all of this is your face. And so you're peeling that back. And now this whole area is really the base of your brain, if you're following my little arrow. So let me go back up. So if you have injury to that base of your skull, bones bleed. And when bones bleed, for example, in an area where, let's say you have the hit behind your eyes, you can get raccoon eyes or periorbital ecchymosis. And I've got the picture coming up. If you get a hit to the level of the nose or the ears in the base of your brain, if you take your face off, you get otorrhea and rhinorrhea, right? The CSF leaking through the ears, otorrhea, or rhinorrhea through the nose. And battle sign, which I'm going to show you, is mastoid ecchymosis. You get the mastoid process kind of behind your ear, and that will show up as a bruise. So here is raccoon eyes. I couldn't resist, so I put in a raccoon. And you can have either unilateral or you can have bilateral raccoon eyes. It just depends on where in the base of your brain you have a skull fracture. And the blood just tracks there. So it doesn't mean that you're necessarily going to palpate an area over the eyes and have them feel pain because they have these black eyes. It is just where the blood landed. Now, this is a very poor example on my part. I couldn't find anything of otorrhea or rhinorrhea, so I decided I would make some myself with my little handy dandy shapes that I added to the pictures. But you can have cerebrospinal fluid draining from the ears, often with a mixture of blood. In order for that to happen, you have to have a ruptured tympanic membrane, your eardrum, right? So patients may be completely alert and oriented and tell you, my ear really hurts because they've got all this pressure of the CSF behind that tympanic membrane. And that pressure can break through, and now you're going to get CSF and blood draining, from your ear. Same thing goes with the nose, right? So if the CSF is tracking down through the nasal passages, it can either come out of the nose, like the person thinks they're just having a runny nose, or it can actually be like postnasal drip. And I had a patient in the trauma center who he was hit in the face with a brick, had a basilar skull fracture, had rhinorrhea, and he didn't realize where it was coming from. And in fact, he developed meningitis, which is a big risk of having CSF leaking out of your nose or really any part of your body, or going down your throat. Right?
On a similar note, and again, it does not have to be a really big mechanism of injury.
Mhm.
Linda had a family member who was setting up a computer, and he was under a desk, and he simply whacked his head under the desk. And for about 6 months, he saw numerous physicians about this constant runny nose he had. And ultimately, one of them diagnosed it. He had a tear in his dura,
Mhm.
and he was leaking CFS for about 6 months.
CSF. Mhm.
So, it does not have to be the car crash. It does not have to be, the fall from height. It could be fairly simple.
So it is something to think about. And in a winter environment, everybody's got a snotty nose, right? So, but just be aware that it may have meaning as well. So, again, I worked in level 1 trauma centers all my life. And so the mentality there is everything is broken until you prove it's not, which has definitely affected my personality, even as a patroller. So I thank the people that are on from Blue Mountain who put up with me. So with mastoid ecchymosis, this is this bruising behind the ear. This may not show up right away, but within a couple of hours, it generally does. And it's also known as battle sign. Concussion. So we see a lot of people with concussions, right? So what is a concussion? It just means that you have some temporarily altered brain function, right? That doesn't actually come with any evidence of injury on CT scans. So if you were to image this person's head, you might not see anything if that's the only injury that they have, but they truly kind of have their quote unquote their bell rung, right? So they may not have ever had a loss of consciousness. You do not have to have a loss of consciousness to have a concussion, but you still can have a period of confusion. People can have some level of non-responsiveness where they're just kind of not responding to their environment in the normal way. They may have amnesia. So if they don't remember what happened before the event that produced the concussion occurred, that's retrograde amnesia. If they can't remember anything after the event occurred, that's anterograde amnesia. One thing that's very common, particularly in pretty significant concussions, is repetitive speech, and that is known as perseverating. And that can make you insane when you've had somebody who is just perseverating. I mean, I've had these people all night. I'm taking care of them on night shift, and it's like, what happened? Where am I? And Larry and I, we had a clip that was actually shown on True TV on the series Ski Patrol. I apologize in advance for this, but we had a snowboarder who came in, and this was real. This was not made up, and he whacked his head. And he kept saying, where am I? What happened? And we kept reorienting him. And what did he say?
Where am I going? You're going to the hospital. I'm going to the hospital? No way. Where am I? The ski area. No way. You hit your head. You're going by ambulance. No way. Over and over and over again.
Yeah, I had a guy kept asking me if he could have a cigarette constantly, like all night. So if people have repeated head trauma, that also worsens the effect. And you can actually have post-concussive symptoms that can last a long time. When I would see patients as a follow-up in our trauma clinic in the hospital, I had a woman who came in who was dealing with symptoms for a good 6 months. When she was really bad, she would forget to wear a particular article of clothing, like shoes, something significant going to work. Or she'd go into the grocery store and all she would see would be white and red labels of, Campbell's soup. But she couldn't differentiate which Campbell's soup she was trying to buy. So you can have some weird issues. And today in trauma centers, you're referred for neuropsychiatric testing and also for some cognitive rehab to kind of help people get back to, their baseline. And this can be a very significant issue, especially for students.
And as you know, as first responders, as EMTs, ski patrollers, pay very close attention to your assessment when you're looking at your previous medical history of the patient. Especially sports injuries, high school, college football. You figure that's just ripe for repetitive head injuries. And as ski patrollers, anybody coming in from the terrain park, it's not that they hit their head, it's how many times did they hit it. So just pay attention to their previous medical history and do they have, previous head injuries, not just today, but in the past.
There is something known as second impact syndrome. So if a person has a concussion and then another in close proximity to that first concussion, there are actually cases where death has occurred as a result of that second impact syndrome. So I am concerned about that, and we do recommend that people do sit it out. And there's varying recommendations. I would look at the most recent guidelines from the American Academy of Pediatrics and some other major sports groups to see where they are now, but at least a week. Some say 2, where they're not involved in a sport where they can they're at high risk for another concussive injury.
The challenging part is this is not something that we can assess and we can really recommend. We can always recommend, but we can't really adequately assess it. It needs to be assessed medically.
Yeah. So cerebral contusions now mean a bruise to the brain, and this is commonly from blunt trauma. And again, I have some pictures that I modified to kind of provide the idea of what's going on here. It is, as I've said, bruising of the brain tissue. You get some capillary bleeding into that brain tissue. And very often this is a result of either a direct hit or it can be that coup contra coup injury. So what that means is that now, within your skull, you've got your brain, which is moving. It could be in that motor vehicle crash that we showed earlier, where maybe in a one type of impact, the brain hits the front of the skull, and then the brain kind of sloshes back and strikes the posterior part of the skull, and now you have bruising on both parts. Same thing can happen in a side-to-side impact. You can have neurodeficits, and that's based on size of the bleed as well as where it is in the brain. If the patient is on any type of anticoagulation, and that includes aspirin, these bleeds can be life-threatening and they can expand. We call them blossoming contusions in the hospital. So I'm always very aware of these. These are not benign types of situations. You've got to worry about them. Okay, getting into the bleeds. Now, I think this is really interesting and hopefully will provide a better visual of what is happening within the brain. So this is a CAT scan image. And what an epidural is you think about the words epidural. Epi in Latin means above, right? So epidural means above the dura, the outermost tough layering of the brain, of the meninges. So as I mentioned early on, the meninges are 2-layered. In an epidural, the bleed occurs between the two firmly adherent layers of dura. So it's like you're splitting these 2 layers, and it produces a really obvious type of image or lesion on the brain, where this is now a convex lesion, also known as a lenticular lesion. Interestingly, this bleed is underlying this area. So just to give you an orientation, this is the skull. this thing here is just the cradle that the head is laying in the CAT scanner. And this tissue above is like your scalp. So, and blood appears as more dense on the CAT scan. So this white area is actually blood. Now, let me go back. Now, obviously, the skull is very dense, so it's very white. Now, if you look at this area, this is the scalp. So you see that there's a little bit of kind of a swelling there. So if we were to be assessing this patient, we might feel some bogginess in the scalp. Now, underlying that, and again, this is in the temporal area, and the temporal bone is the thinnest bone in your skull. So underlying that area is the middle meningeal artery. And when you tear that artery, you get an epidural. So this is an epidural hematoma, and it is an arterial bleed, and this can produce a very rapid rise in intracranial pressure. We'll spend some more time on that in a little bit. So patients can initially have a loss of consciousness, and that's from the initial bleed. When arteries are cut, they constrict to actually stop the bleeding. And that's why you may wake up and have that perfectly lucid interval where you seem fine. So now the person's in the patrol room, they've woken up, I don't want to go to the hospital, I'm good. And you have no clue whether this is now that short period that you have before that vessel opens up again, cuts loose, and now you have more bleeding and the patient deteriorates. And this is where brain herniation can occur. And again, I'm going to speak more on brain herniation in a little bit. These people need emergent surgery for survival. So here is some pictures from cadavers. These were unfortunately real people, and they had medical examiner exam. So this is a good picture of the meninges. And this is a picture of the epidural of what it actually looks like. It looks like a big blob of black currant jam, right on top of the brain. And you can see in this person's skull, there's room, right? There's the brain, but you can see how much room there is in this person's skull. And if we were to look at the image on CT, this is what we're seeing. And Larry talked about the fact that it's not smooth inside that skull, and it isn't. So there's all kinds of little ridges, right? But this is the epidural. It's sitting right on top of the dura. And hopefully we get it before, we take care of it before the person is now on a medical examiner's table. But they go in, do a craniotomy, and literally not only remove that clot, but then they have to then oftentimes prevent, that area from continuing to bleed with the techniques that they have to stop cerebral bleeding. So again, epidural, whoops, wait a minute. Here is just a CT series that taken sequential cuts through the brain in images. I just wanted to point out that, you can see that this thing is just developing here. This darkened area in the middle of the epidural just indicates an area of active bleeding. It's getting bigger and bigger and bigger. And the other thing, there is an area that between the two cerebral hemispheres, and it's this midline, right, of the brain. And the midline should be just that, midline. When you start to see this line being pushed over, that actually indicates brain compression. And when that happens, the area of brain tissue on this side is not getting the perfusion that it needs, and then you can start to get cerebral ischemia and death of brain tissue. So ultimately, this is a patient who, if you don't get them into the OR quickly and evacuate this, they can herniate. And that means the brain is kind of coming down through the foramen magnum or through another, maybe a skull defect, like an open fracture. It finds a lot of ways to escape the skull, unfortunately.
For those of you that remember, there was a pretty popular actress several years ago who died shortly after a ski accident up in Canada. And it's exactly what happened. She apparently fell. She must have had a loss of consciousness at the scene. She got up, she refused help, and the ski patrol actually followed her back to her lodge. And they watched her, and when they saw her starting to decompensate, They called for help. They got her to a hospital, but at that point it had been too late. But she'd had that initial loss of consciousness and then a lucid interval where everything was fine.
Essentially, once these people have these types of injuries, the bleed occur, our goal is to get them into the operating room within a 2-hour period on the short end of that as well. These can progress very, very quickly. The other type of bleed is called a subdural hematoma. Now, below the dura, so sub meaning below the dura, you don't have these firmly adherent layers that now are trapping that blood into that kind of convex or lenticular lesion. In this case, the bleeding just sort of flows down from usually a vein. These are usually venous bleeds, but don't feel like that's okay. Okay, so these can really accumulate, and they can also accumulate pretty quickly. And there's kind of two situations that I worry about with a subdural. One is in an older person. Okay, like the definition of older is getting older like each year. and that's getting scarier and scarier. But in an older person where you have a lot of room in your skull, it doesn't take much for your brain to slosh a bit and tear a subdural bridging vein and produce one of these. In fact, someone simply falling to their knees, they don't even hit their head, but it's a hard jolt is enough to tear a bridging vein in some patients. Now, in a young person, it takes a hard hit to produce a subdural. And so you kind of see two different things. So you can have a sudden onset, or you can have a delayed onset. Ronald Reagan, one of our previous presidents, fell off a horse. He had a very delayed onset with his subdural. He probably had some room up there, right? So let me just kind of show you what this looks like. So again, here's the CT image. Here's the dura reflected back. And now we have this big blob of blood. Okay, again, it's a postmortem picture that is literally sitting on top of, sitting below the dura on top of the arachnoid. And the issue, though, if we look at these pictures, these are two different CTs. They're not from the same person. Remember I talked about that midline. If you have a lot of room in your head because your brain is atrophied, yeah,
It's 25 degrees outside. There's a mosquito flying around the house. Sorry.
And it will bite me, I guarantee it. I was watching it on the wall too. Very distracting. Anyway, so with the person with a lot of room up there, their midline of their brain, there's only a little bit of shift here. And even though there's a lot of blood accumulated, they're actually not doing that badly. Go over to this other picture. This is your classic young person, right? Where they have a very tight brain in their skull. And it takes a hard hit. The problem in a young person with a subdural, not only do they have the bleeding, but they have brain swelling. It causes a tremendous amount of inflammation. And when a neurosurgeon goes in to do a craniotomy where they're taking a piece out of the skull to kind of get in and evacuate that hemorrhage and then stop that bleeding, that brain literally comes right up through that defect that they create surgically. And sometimes they literally have to open up that skull in order to let the brain swell and they have to freeze the piece of skull that they remove until they can go in later. And we're talking maybe weeks or months later to actually put that piece back on the skull when the brain comes down. But this is a very high risk area for death in head injury, subdurals. Bleeding within the brain substance, these are the intercerebral hemorrhages, and this could just be from a hypertensive bleed or stroke, or it can actually come from trauma as well. And how big it is and where it is really determine the prognosis in this type of bleed. Okay, is everybody still with me? I want to cover at least a little bit about intracranial pressure before we take a 5-minute break. So intracranial pressure, there is something, is that okay? Great, awesome. The Monroe-Kelly doctrine. And so the simple concepts are that your skull is a rigid box. only like right after you're born for a while. Do you have sutures that haven't quite fused yet, where, you know, you may not have that rigid box? But put it this way, you know, after, you know, year or two of life, like your skull is rigid. And you've got brain, blood, and CSF. So there's three things in your head. And sometimes it feels like there's three things in your head. You know, I have some days like that, right? And normally within this box, you have a very low pressure system. So if we were to like take the blood pressure of inside the skull, it would be between 0 and 15 millimeters of mercury, as opposed to blood pressure like 120/80. So it's low pressure. What raises pressure? When we cough, when we sneeze, if we're straining for some reason, having a hard bowel movement, you know, what, all those things raise the pressure. Now, normally that's not an issue because the pressure is not going up that high. However, if you have brain swelling, that can increase brain. If you have blood accumulation, like through a hematoma, we can also do that if we put a C-collar on too tight and we compress the jugular veins and we prevent the brain from draining. The jugular veins drain the brain, so we want to make sure that we don't ever put a C-collar on too tight. And we also can have an increase in CSF, so cerebrospinal fluid. In a case of this, if we have bleeding in the subarachnoid space where the CSF is produced, if you have bleeding there, those red cells actually clog these little villi that actually will allow that CSF to be reabsorbed. So you produce like 300 mils of CSF a day. We only have about 150 mils any given time circulating. So if we clog up our little villi, the CSF is being produced and it's not being reabsorbed, and now we've got pressure going up. So what happens? So an increase in any one of these without a decrease in another will cause pressure to rise. And there's the darn mosquito. I'm sorry. So you can see that for a while we can compensate. We can, you know, constrict the blood vessels. We can auto-regulate what's going on in our brain. We can stop production of CSF for a while, but only to a point. And then all of a sudden, boom, pressure goes up, and now we have a bad situation. Do not let this slide intimidate you. So my message here, in order to get blood flow up into the brain, you need a certain pressure. That pressure is called the cerebral perfusion pressure. And it is determined by two things. It is determined by blood pressure, and it is determined by your intracranial pressure. So what does that mean for patrollers and EMTs? We don't want our blood pressure to drop, because if our brain is swelling, and we need more blood pressure to actually get blood up into the brain to keep the brain perfused while this brain is swelling, right? So in the hospital, we can measure mean arterial blood pressure, and there's a equation, and we can calculate it based on taking a blood pressure, but not that I'm advocating that we do that. We can't really measure ICP. We can just get a sense that it's elevated by some of the signs and symptoms that we're seeing, and we're going to talk about that. And those together, we know, make up cerebral perfusion pressure. So we do have interventions that we can do as BLS and ALS providers that can help the situation and keep that perfusion intact to the brain, or at least to the best of our ability. Within brain injury, so what happens is you have some primary hit. It might be the motor vehicle crash, or the you know, skier into the tree, you know, whatever the situation. Unless you can stop that injury from occurring, you can't really do much with the primary injury. So just like any tissue in your body, your brain will swell from that. And then when your brain swells, your intracranial pressure within that rigid box starts to rise. And then you can start to get some decreased perfusion pressure because ICP is going up. And if we can't get the ICP down, or the blood pressure to compensate, we start to get lack of flow and ischemia, or so we have inadequate perfusion to the brain. And then the brain, as I said, it can only do so much when it comes to trying to constrict vessels or trying to shut off the flow of CSF. And ultimately that gets lost. And then you get what's known as secondary brain injury. So this is the complication of all of the swelling and things that are going on. And it is made worse by things that can be happening in addition to that primary injury. So if that patient starts to get hypoxemic, right, they don't have adequate oxygen saturation, that is actually depriving oxygen to the brain more. If their blood pressure drops, they're not going to have enough pressure to perfuse a tight, swollen brain. Hyper and hypocarbia, that talks about your state of your carbon dioxide in your blood. Carbon dioxide in your blood is a potent vasodilator of your blood vessels in your brain. So if you have too much carbon dioxide, meaning the person's not breathing adequately and we're not doing anything about it to ventilate them, then we're actually going to cause more blood to be going up in the brain when maybe it's too tight already. By the same token, if we hyperventilate them and we blow all that CO2 off, the vessels can constrict to the point that now we don't have enough flow coming in via the vessels and the brain can become ischemic. So we want a normal level of carbon dioxide. Hypovolemia. So let's say that patient with that head injury also has a pelvic fracture, has abdominal or a spleen injury, for example, or bleeding, excessive bleeding. They're going to be in bad shape, and that secondary brain injury, can be made worse. Coagulopathy means they're bleeding from maybe taking an anticoagulant, from taking, like aspirin or Plavix or Coumadin or any other such thing. Or maybe they have a coagulopathy because there are people that have diseases that produce these issues. People who are hypothermic, they bleed. Bleeding is a process that is controlled, or blood clotting is a process that is controlled by temperature. So if you're hypothermic, you bleed more. And then, of course, your brain swells anyway. Your brain is going to get ischemic as a result of the swelling. And you wind up with a situation with increased ICP and decreased CPP.
So as pre-hospital providers, look at that list. And which ones of those can we, as, say, BLS, providers, which ones of those can we address in the field? Can we address hypoxemia? Can we address hypotension?
That might be a matter of positioning. It might be a matter of stopping bleeding, right?
Proper ventilation. We can address hyper or hypocarbia. We can try to address hypovolemia by stopping obvious bleeding. Coagulopathy, as Linda said, hypothermia leads to coagulopathy. So maintain their body temperature. So we may not be able to do everything for them, but there are very basic techniques that we can do, which will address many of the causes of secondary brain injury.
Eric, do we want to take 5 here?
Yeah, we can. So,
Is that reasonable? Okay.
yep, that works for me.
All right. Great. Thanks.
All right, so everybody be back at 8:06.
8:06.
Six minutes trying to hunt down the mosquito.
So far, so good.
Okay.
Yeah. So far, I have 53 people attending. There's a couple that I don't know who are on here.
Okay.
So you had a good turnout.
Fantastic. That's great. I'm very happy about that.
Yeah.
Understandable. Is anything that I need to go back and emphasize from your standpoint? I mean, I'll be asking questions of the group to at least give us feedback as far as
Yeah.
hopefully
The only thing I noticed in the very beginning, just as an instructor critique, there's a lot of ums and ah.
okay.
Other than that, I think you guys were spot on. So,
Cool.
Okay. Awesome.
Probably in the chat.
Yeah.
Hey Larry, Rich Snyder.
Yeah.
You talk about your mosquito. We had a snapping turtle in our patrol room today. Something's weird going on in the world. Yeah, we were cleaning the room and we thought we had a dead turtle. My kid picked it up, it was a snapping turtle.
Jeez.
My God.
So he's a walk-in patient.
Pretty much so. It took him 2 weeks to get into our patrol room. We find a nice place near the hot water heater, and we took him out to the pond and threw him in the ice.
He didn't want to be there. He was in the
No.
patrol
I know.
for a
I
reason.
told my kid, I think he could send his relatives after us one day and bite us.
My goodness.
So you have your mosquito. I had a snappy turtle today.
Yeah, who knows where these things, come from? But yeah, I see it.
Yep.
I see the guy. It's awesome. We don't want the mosquito to get any of our cats either. So,
I'm just waiting for your eyes to just get big and
yeah, I think, yeah, no, he decided it's probably a she. Was hanging out by our light. So, yeah, Larry said it's always a she.
Hmm.
Well, we'll find it.
yeah,
I real
oh,
yeah. I realize,
but
when people, if we ask a question, we're not seeing any comments in the chat. So
yeah,
we only get the ones if they unmute and say something. So
yeah, I was watching it. There's only a few in there.
okay, if somebody's got something,
Yeah, I'll
significant.
point it. I'll raise my hand or I'll point it out to you.
Okay.
Um, yeah, that's not a problem. Now that I have the roster pretty much down. Uh, like I said, only a couple of people that can't figure out who they are. I have a funny feeling one of them is Wolfgang. He likes to change it up on me.
Secret shopper.
Yeah, pretty much. All right. Once I get to 8:06, we'll get started momentarily. First of all, a little housekeeping. There are a couple of people. The way their screens are, I don't know who you are. It's iPhone number 2, ZB. Someone put their phone number in. Last four numbers are 4095. Then it looks like Land OLVIJ. And then the last person is AECSO. So if you could please put your name in the chat so you get credit. Other than that, I'll turn it back over to you guys.
We're going to start off again with assessment, looking at the signs and symptoms of brain injury. This is part of our general assessment of any patient that we see. Obviously, head lacerations, contusions, and hematomas. You're palpating, obvious bleeding. Do you see bruising? As we palpate, are you seeing visible fractures, deformities, depressions? You palpate the head. You palpate the base of the head, the base of the neck. Are you seeing anything obvious? We talked earlier about, as you palpate the skull, are you feeling any bogginess, soft spots, particularly in the area of impact that's been reported? The raccoon eyes and battle sign. It may not be present immediately or for a period of time. So if you're a first responder and you get there 15, 30 minutes, after the incident, you may not see it. But if you get that patient who wanders into your aid room or calls the ambulance after several hours after the injury or the next day, and you see this, it may be much more prominent. If you see cerebrospinal fluid in the nose, in the ears, perhaps even in the mouth, the patient may complain of a salty taste in their mouth. Could be an indication that they've got CSF leaking. Abnormal pupil responses and abnormal pupil shape. Keep in mind, some people may have this from a previous injury. Some people may have some congenital abnormalities in their pupil response, but pay attention to pupil response and shape. Any loss of sensation or motor function, you do your assessment. Do they have, sensation in all extremities? Do they have equal motor function in all extremities? Tell them to squeeze your hands. They can squeeze one hand really tight, the other one, you feel obvious weakness, indication that you may have a problem. Changes in level of consciousness, amnesia, combativeness. We always talk about the combative head injury. They're not always combative. They may be sleepy. Obviously, any mental status change is something to be concerned about. Vital sign abnormalities, Cushing's triad, you get it. We'll talk about it later. Seizures, seizures very common following head injuries. And nausea, vomiting, visual complaints, headache, dizziness, balance problems. Any of these can be signs of brain injury. Keeping in mind, they can also be signs of other problems.
There are possible causes of neurodeficit that may not be trauma related that you just have to keep in the back of your mind. We may not know from the initial outset what is actually causing what you're seeing in your assessment. However, we do have to keep in mind that many people drink alcohol or they may do some sort of substance, right? They may be diabetic and have hypoglycemia, hypothermia, or hyperthermia if you're now in the summertime and you're maybe responding for the patrollers who also do coverage of event medicine, like Spartan races or the mountain biking, or you're an EMT and there's a potential patient who has been out in the sun, exercising, and now they're hyperthermic and they can go into heat stroke, and that is a true medical emergency. TIAs and strokes may also present this way, so we have to think about that. Brain tumor. So on ski patrol at Blue, I responded several years ago to a woman who was seizing in the middle of one of our green trails. And she was in status epilepticus, meaning her seizure was not breaking, to the point that she was seizing the entire way down to our aid room. So I rode in the sled with her. I had to constantly suction out her mouth because of the bleeding that was occurring from biting her tongue and all the secretions. She continued to seize into the aid room, and the medics came, we called for a helicopter, and they hit her with Valium, and anyway, they transported her. They couldn't get her seizure to break, and she seized for another 3 hours in a hospital in Pennsylvania. And ultimately, they had to put her in a barbiturate coma to stop the seizure. And she had a brain tumor, and she actually manifested this brain tumor for the first time at the ski area. So it was a pretty crazy situation. I wound up getting a Purple Merit Star for it, but it was unlike anything that we expected. So people can have seizures, and they can have a postductal period after the seizure. You may not have seen the seizure. It may not be head injury related. It may be their underlying seizure disorder, and they may have that altered mental state as a result. So you've got to think about that. And people who are septic, who have, I'm thinking some of the different endocrine disorders, severe hypothyroidism, Other things you may see in the community, these can also cause profoundly altered mental states to keep in mind that may appear like a head injury. And they may be a concurrent finding with a head injury as well. Doesn't mean that if they have that, you can rule the head injury out if there's a fall or some other mechanism that you're concerned about. We've all learned about assessing level of consciousness using the AVPU scale, which is probably the simplest scale to use. You know, suffice to say, it's something that you can keep in your back pocket. And if you don't remember the Glasgow Coma Scale, at least be able to say how the patient falls on this AVPU scale as far as your assessment goes. I want to spend some time on the Glasgow Coma Scale because oftentimes this is confusing for people. My recommendation is that you have some sort of a little printed cheat sheet, a little card, something laminated that you can keep with you in your pocket, or for the patrollers to keep it in their pack. And then you at least have that as a resource you can use, so you're not trying to commit this to memory. I did this so often on patients because I worked in a neuro unit and worked with many neuro patients over the years that I memorized it, and it just became second nature. But unless you're using this all the time, people don't memorize it, right? It's something that you need a cheat sheet for. So eye-opening, very easy. You know, is it spontaneous? Meaning you walk up, the patient's eyes are open, you know, they look like they're engaged with their environment. Not that their eyes are open and kind of there's nobody home up there, right? So you can kind of tell the person's tracking, you know, they're engaging with you. If the person is sleeping and you wake them up and then they stay awake and they don't go right back to sleep, you can say spontaneous, right? You don't lose a point on the Glasgow Coma Score because you're just asleep, unless the sleeping is abnormal. Do eyes open only to voice, meaning you have to shake, or excuse me, you have to shout at them to get them to wake up? Do eyes only open to pain? So now you have to do nail bed pressure or sternal rub or whatever pain mechanism you're inflicting upon the individual. Or no matter what you do, is there no response? Realize there are no zeros on the Glasgow Coma Score. 1 is the lowest you can get in any one of the 3 categories. Best verbal, oriented. They know, you know, they're awake, alert, oriented to person, place, and time. Are they confused? Now, if they don't know the date, half the time I don't know the date, right? Like, you have to kind of like just use some judgment here. If you tell them the date and they remember the date, that's great. I wouldn't take a point off because of that. But if, you know, you're at a Bear Creek ski area and, you know, the patient tells you they're in Colorado, okay, clearly there's now a problem, right? Because they're not even in the right state. So use some judgment. If they don't know who they are, where they are, kind of the things that you would expect, now you have an issue. Inappropriate words, that may be inappropriate conversation. It could be the person is cussing at you, right? Because of that frontal behavior. It could be that they're having a conversation that does not relate to the questions that you're asking them. But they're words that you can actually discern words. Inappropriate words incomprehensible words. That's now where a person is moaning, screaming, gibberish, you know, whatever. And then none, there are no words. Motor response is probably the best prognostic indicator of how well this person's going to do in the grand scheme of things. It takes a lot of brain function to obey commands. So if you ask them to, you know, hold up 2 fingers or squeeze my hand, or, you know, something where you can actually get them to do something that is reproducible. Now, squeeze my hand may have some issues because that can also be reflex in certain situations. So asking them to stick out their tongue, or, you know, blink their eyes twice, or, you know, again, holding up 2 fingers is a good way to assess for that. If they're not spinal cord injured, right? Maybe the stick out your tongue might be the spinal cord injured patient way to check if they can obey commands. Localizing pain means now they're not obeying commands, but if you apply a pain stimulus somewhere, let's say the paramedics come and they're putting in an IV and that needle goes in. It's where the other side of the body literally is coming across the midline to try to remove that stimulus. So they're trying to rip out their IV. Okay, that's a very purposeful response. They can localize where that pain is occurring. However, the next level down in worse cognitive response is actually, or overall level of responsiveness response is now where they are withdrawing to pain. So the needle goes in. They no longer can localize to try to pull the needle out. They are literally trying to roll away from it because they don't have that ability to discern where it's happening. There's also two other types of motor responses, flexion and extension. And the best way for me to show you this is just to kind of go through this picture. So there's decorticate and decerebrate posturing. Decorticate posturing is also known as flexural posturing, where now you're actually seeing a person extend their legs rigidly, they're pointing their toes, and they're pulling their arms up to their chest. They're pulling up to the core. It's kind of one way to remember it. You have the normal person in the middle, and then as that brain swells more and they're going down even further on that coma scale, decerebrate posturing is where now they're extending, and you can see they're rigidly extending their legs and they're rigidly extending their arms. And it is possible for someone to have a decorticate posturing on one side and decerebrate on the other. So when you're putting in the Glasgow Coma Score number, it's always best motor response. So you would be putting in the number that corresponds to decorticate as opposed to decerebrate, because decorticate is the best motor response. So you can see that flexion is better than extension. And then beyond that, there is no response. So ultimately, the total score, hopefully, of all of us sitting here tonight is 15. The score of the desk in front of me is 3. There is no 0 score. Hopefully that helps, and we'll have some time hopefully to talk through this if anybody has any questions about Glasgow Coma Score. But most of the confusion is usually around that motor response and that flexion and extension posturing. So Larry mentioned pupils. And so when you're assessing pupils, the proper terminology is PERLA. Now, we can't always assess the A, and I'll talk about why that may be, but we want to look at the pupils and are they equal? And not only are they equal, when you're just looking at them, but when you shine a light in the eye, do they constrict equally? Or did one kind of constrict very well and the other one was sluggish? So you're looking at both. And of course, that's reactivity as well. Are they round? Are they both round? Are they reactive to light? And for the people who are able to follow commands, do they accommodate changes in the position of whatever object, or do their pupils accommodate to where they're shifting their gaze? So for example, if you're holding a pen light up in front of them, their pupils, are some level of, so many let's say they're 4 millimeters, and you ask them to look across the room, you would expect that those pupils would dilate to see that object at distal in the room. So the pupils are constantly constricting and dilating depending on the location, how close or how far an object is, but also to light when you're shining light in the eye. So, when you shine the light in one eye, the other eye should be constricting as well. So you're checking that when you're checking pupils. Okay. Just be aware too that if you take a direct hit to the eye, the pupil can be widely dilated. And so it may not necessarily mean that there's something going on in the head. It just may mean that they've had direct eye trauma. They can also have had surgery to their eye, which may mean that their pupil is not going to react normally or react at all. And there is a percentage of the population, it's a small percentage, that have congenitally unequal pupils, and it's usually not a huge difference, but you may see that and you may ask the person, is it normal for your pupils to be unequal? And they should know whether the pupils are normally unequal.
Then there's artificial eyes.
Larry's saying, and then there's artificial eyes. Yeah, there are artificial eyes. So, Okay, so we talked a lot about brain swelling, and we can get into the whole concept of brain herniation. So what brain herniation means is that the brain in that rigid box is now trying to be forced down through, usually it's either foramen magnum, the hole in the skull where your brain stem then becomes your spinal cord and goes on from there. So the brain stem can be forced down through that foramen magnum. There's a few other places where the brain can herniate, and if there is an open skull fracture, the brain can literally push right out of an open skull fracture. I had a patient, we were resuscitating her, and we had to check her back for injury, and we turned her, and literally she had brain matter coming out of her nose because she had a basilar skull fracture, and it wasn't just CSF coming out the nose, it was actually brain matter. So hopefully you will not have to see that, but it can happen. It can come out of the ears as well. And so what you will see is a rapid decline in level of consciousness. Ultimately, the GCS will become 3 once herniation has occurred. You may also see this widely dilated ipsilateral, meaning same side pupil. So you got a bleed going on here, and you've got a pupil on that side. That's the one that's dilating. So if a person is sitting there talking to you and they've got this widely dilated pupil, I can guarantee you they are not herniating their brain. Okay, there's something else happening where they had direct trauma to the eye, or they saw the eye doctor and got drops and their eye is dilated. But when the pupil dilates like that, it is along with the other findings that you're seeing, that decline in level of consciousness. Okay, these things don't happen in isolation of each other. When that swelling is so great, you can actually have Cushing's triad. Larry mentioned Cushing's triad. What is it? So widened pulse pressure. It means your systolic blood pressure is going way up. And if you take systolic minus diastolic, that number is going higher, right? So the thing you're going to see clinically is really profoundly increased blood pressure. And that blood pressure is going up as sort of the body's last ditch effort to try to get perfusion up to a very tight brain, very tight situation going on within that cranial cavity. At the same time, because now there's pressure on that brain stem, bradycardia occurs, so heart rate drops, and you will see some alteration in respirations. So it could be that they're having rapid breathing, it could be they're having periods of apnea and no breathing, all manner of different patterns of respiration depending on how that brainstem is being compressed. Just know it will not be normal. These people will need some assistance with ventilation, and they are certainly not at the point where they're going to be communicating with you. Okay, they're pre-death at this point in time, and it's going that direction very, very quickly. Comments? Okay. So, head injury management.
For head injury management, we go back to the basics. CABCD. So C, you're looking for massive hemorrhage. Now, I think in the EMT book, it refers to as XABCD. In wilderness medicine, it's March. You start with M for massive hemorrhage. But we're back to you're trying to identify and stop major life-threatening hemorrhage, not the minor stuff, but just major life-threatening hemorrhage. So look for areas of external hemorrhage and wound pack it, throw a tourniquet on it, whatever you have to do, stop the bleed. You want to avoid hypotension. As we said, if the blood pressure drops too far, the brain is not going to be perfused. So your systolic blood pressure goal is greater than 100 millimeters of mercury. So to prevent inadequate brain perfusion. So direct pressure, wound packing, hemostatic dressings, tourniquets, whatever you have to do. You want to make sure you support oxygenation and ventilation in these patients. So you've got to maintain a patent airway. Because it's a head injury, there's always the potential for spinal injury. So preferably open the airway with a jaw thrust if the patient can't maintain their own airway. If you cannot maintain it with a jaw thrust, you may have to do some head tilt chin lift. It's a last resort, but you've got to maintain that open airway. Administer oxygen. We're generally going to start with 15 liters non-rebreather mask. You're trying to, if you don't have any other means of determining pulse ox, keep in mind in a winter environment, pulse ox may not be, portable pulse ox may not be real accurate. So start with high flow oxygen, and as soon as you can, titrate it down. You're trying to maintain a pulse ox between 95 and 99%. If these patients cannot maintain their own respirations, you maybe have to use a bag valve mask to ventilate them. Obviously calling paramedics in for airway maintenance, put in airway adjuncts, oral pharyngeal airway, nasopharyngeal airway. Keeping in mind with nasopharyngeal airways, you're always worried about nasal or facial fractures. You've got to avoid the hypoxemia. So you're shooting for at least greater than 90%, but your goal is greater than 94% oxygen. Way back when, we used to hyperventilate patients with head injuries. We don't do that anymore. You don't want to hyperventilate them with a bag valve mask because it can decrease cerebral blood flow for the reasons Linda said about hypercarbia.
So also, for those ALS providers that may be on the call, the end tidal CO2 goal, if you do have an end tidal CO2 quantitative device, is 35 to 40. That's basically normal, right? If we push it, again, if the end tidal CO2 is too high, then we're going to get cerebral vasodilation, get more blood up into the brain, but not in a way that we want. And if it's too low, we're going to have cerebral vasoconstriction, and we're not going to get enough blood up into the brain. So we want it just right. If you do have to bag valve mask someone, AHA recommends 1 breath every 6 seconds. Now, there may be local protocol where in the case of an imminent brain herniation, that medical command may give you an order to do some degree of hyperventilation, in which case, if that is what is required, you want to keep end tidal CO2 between 30 and 35 and nothing lower. But really, we're not doing it unless there's a situation where, again, you're directed to be, or it's in your local protocol due to impending brain herniation in a terminal state.
And remember also with using a bag valve mask, you're looking for chest rise to determine adequate ventilation. You're not trying to overventilate them.
Okay.
Some key actions. We go back to head injury, gives you a high incidence of potential spinal cord injury and the need for spinal motion restriction. Again, we go back to our local protocols. Some states have eliminated spine boards altogether. But, follow your local protocol, consider the need for spinal motion restriction, put a cervical collar on, but as Linda said earlier, make sure it's not too tight because you don't want to inhibit the return flow through the jugular veins. Consider head of the bed elevation 30 degrees to lower intracranial pressure if they're awake and there's no high risk for spinal cord injury and they're not hypotensive. Keep the head in midline as much as possible. So your patients, if they're laying down, your patients should be sort of eyes front neutral position, head in the midline.
And that is if moving their head to the midline does not cause more pain or some sort of neuro deficit, right? So this would be that patient who can tolerate that position. And even with the head of bed up at 30 degrees, if they're in a C-collar, that's going to help in maintaining that neutral inline position. When the head is cocked off to one side, again, that also impairs jugular venous outflow and can keep more blood up in the cranial cavity. So we want that free flow of jugular venous drainage to, again, lower that ICP.
If you put the patient on a spine board, you can stack some blankets, pillows underneath the head of the board to elevate it.
So this is a discussion point. So how does this position impact ICP? And maybe Eric can unmute so we can actually get people talking.
It's fine.
Anybody?
The cerebral venous drainage won't happen as fast.
You can increase it.
Go
Yeah,
ahead.
we have 4 together on the intersection that they just tore down.
Susan?
Yes, Susan, are you trying to say something?
No, no, I'm not at this moment.
Okay. All right. And I thought it was potentially Robert who also said something. Maybe. All right. So,
No, I'm sorry, I'm good.
okay, you're good. All right. So when the head is flat, you can actually have increase intracranial pressure due to a flat positioning. And part of that may be, decrease in jugular venous drainage, but just the idea of increasing head of bed elevation is enough also just to improve ICP dramatically. I mean, it's interesting when patients actually have ICP monitors in hospitals and you can watch this. There would be times when we would have to put the patient flat for whatever care we were providing, and we would see ICP go right up. And as soon as you elevate the head, the ICP went down. So it does really matter. So there may be times when you're going to have to use a spine board and, cervical immobilization device, collar, all of that. But just realize that there can be a downside to it, so it's using clinical judgment. It's sort of like, what is the biggest risk to the patient at that very moment in time?
Mm-hmm. Keep in mind too that some people on spine boards have a greater difficulty breathing.
Mm-hmm. Okay, anything else on that? All right. So with your head injury management, you're going to frequently assess and reassess patients because they can change. You're really looking at trends, vital sign trends in particular. Really what is happening. Now, if the person is really excited and they're still mentating properly and their blood pressure goes up, I'm not looking at that as the beginning of Cushing's triad. Again, put it all in context of what you're seeing with the patient. If their level of responsiveness is dropping rapidly, their pupils are getting sluggish and the pupil is starting to get very large. And now, we're starting to see bradycardia and that blood pressure going up. Now you have an issue, right? So now I'm much more concerned. I'm very concerned at this point. These are people who are at high risk for seizures. Anyone with a head injury can have seizures develop as a result because that edema, that swelling of the brain can make that brain much more, prone, I guess is the better word, to seizures. If they're having any CSF flow from their nose or their ears, don't stop it. That's kind of a pressure release valve. So what you can do is take a rolled up piece of sterile, if you have it, gauze, and just tape it to the nose. Or you can put a piece of sterile gauze against the ear and just tape it there. And then as it gets saturated, if it does get saturated, you're just going to change it. It's not stopping the flow. It's just catching the flow and hopefully preventing other things from going in. At this point, if you are an ALS provider and you're going to have to give any kind of sedation or a paralytic agent, analgesic agent, make sure that you get a neuro assessment of some sort before you sedate. It was always challenging in the trauma center when we would have a patient brought in and we had no baseline assessment at all. And that baseline assessment, even if it's just a couple of seconds of what are they doing for you, what's their best response, really helps with the prognosis of that patient in terms of planning their care. So it really does matter. Sample history, what I'm worried about is people taking anticoagulants. So that is probably the most important thing. If there's an alert bracelet, medical alert bracelet, or maybe a person, a friend or a family member is with the person who can tell you that, they're taking aspirin regularly, they're taking, warfarin, whatever it is, report that off, because there are things that trauma centers have to do right away. Many of these agents can be reversed with the right drugs. Some can't be, but there's other agents that can be given to try to mitigate the effects of that bleeding. And clearly they need trauma center care. Hospital interventions, what you're going to see, and this will run the gamut depending on the nature of the injury. These patients will have IV fluids. Clearly, they're going to try to maintain not overhydration, but normal hydration. Blood products, if they're bleeding, they may need the blood products also to elevate blood pressure in certain cases. Vasopressors, meaning drugs that will raise blood pressure, that may need to be given to support the perfusion to the brain, particularly after the person has already been resuscitated. If they were bleeding, that their blood loss is corrected. Now they also have to add the vasopressors because of the brain injury, actually maybe brain stem involvement that is causing problems in blood pressure, and you need something to tighten up the vessels to get that perfusion to go up. They clearly will need imaging and potentially surgery to remove that clot and control the bleeding in the brain. They may have monitoring devices put in, which could be an ICP monitor, or actually a device that will allow the cerebrospinal fluid to drain out into a bag. So when the pressure gets up too high, that excess fluid can be drained off. And then there are drugs that can be given as well. Mannitol is one of those drugs. It's a sugar. It's an osmotic diuretic, meaning it kind of pulls excess fluid off the brain. And basically patients then urinate it out and can decrease the pressure in the head, and sedation and paralytics often. But there are many other interventions that are done. If you have an interest in this, if you are an ALS provider, nurse, physician, the Brain Trauma Foundation guidelines are really the standard of care. And you can Google Brain Trauma Foundation guidelines and get some really great guidelines on what happens in the pre-hospital arena all the way through the hospital care of these patients. So highly recommend that. Now, back to the case scenario.
So we're talking about our mountain biker again. So your neighbor called you because you're a ski patroller, EMT, paramedic, nurse, doctor. Husband was mountain biking, fell hard on a paved trail, hit his head. Now he has a bad headache, feels nauseated, wants you to come over, and he's refusing to go to the ER or urgent care.
Yep, hold on.
What are you going to do?
Actually, I just gave it away. Sorry. But let's talk about this. This is our group discussion part of the program here. So, we're taking you out of your normal comfort zone, right? You're not working now in your normal role. You are a neighbor.
So what do you?
That helmet, that tells you a lot.
Okay. Yeah, that's the helmet. Obviously cracked.
You want to send that along with the patient.
Okay. Yeah, we'll assume scene safety is taken care of and you're wearing a pair of gloves, so.
Medications they might be on.
Okay, good. Good.
Yeah. Coumadin, any blood thinners.
Is he on blood thinners, anticoagulants?
Aspirin.
Good.
The amount of kinetic force to cause that type of damage, I'm thinking of other injuries systemically throughout that patient.
Good. Good.
Including spinal.
I was just gonna say,
Good.
absolutely spinal, neck.
Okay, good.
Oops, sorry.
How soon after the injury did they get your attention?
What was that again?
How soon after the injury did they get your attention?
Good. How long ago did it occur? Very important.
Was anyone riding with them and saw what they hit, how they hit it, if they lost consciousness?
Good. So you get a better idea of mechanism.
How clearly are they speaking?
Mm-hmm.
Do they have headaches?
Changes in the time you're with them from a baseline.
Okay.
Essentially, you would go through your sample thing, as you would, as long as they can communicate with you.
Exactly. Exactly.
Well, also possible abdominal injuries from hitting the handlebars or something.
Mm-hmm. And besides just the injury, why would that be important?
Internal bleeding.
Internal bleeding, good. The chance that they've got bleeding, which is going to obviously affect any head injury they may have.
Do they have any other lacerations or injuries?
Mm-hmm. Good.
What medications are they on? Basically, like everybody's been saying, our sample.
Good. Good.
I wonder next, getting all the information, the sample, what happened, etc. As a neighbor, you may be more able to convince this person to go to a hospital rather than a spouse. Okay. At the same time, if their injury is potentially that bad, with the spouse's permission, you might still be able to call an ambulance. But, there have been times I've been able to get people to do things when their family couldn't.
Right, right. Because you're the, at least at that point, you're the expert.
Right. I'm an expert and an outsider.
Right. And that's one of the challenges is what are you going to say to this individual to convince him to go to the hospital? And as you pointed out, you may have to call EMS, because one thing that you don't have at that point is medical control. Mm-hmm. And if you can get EMS there, he may still want to refuse to go, but EMS can put him on the phone with the local emergency doctor who he may be able to convince him to go.
So amazing. You were spot on. Like you must have written this part of our slide for us here. So how do you have that convincing conversation? Someone convince us that, we need to go to the emergency department.
Well, it may be the difference between going to get looked at for a day or two or winding up in the hospital for a long time.
Mm-hmm.
Okay. And what their absence, long-term absence might mean for the family, etc. So, you can guilt trip them.
I like the way he thinks.
I love that guilt trip.
Oh, yeah.
You might take the tack to tell them, look, I'm not a doctor. I'm just a first aider. You really got some bad injuries and you need to consider the long-term effects if you don't get looked at.
Right. Right.
Absolutely. Sometimes, one of the most challenging things is to try to convince someone to get the care that they need, right? On all levels, whether you're on the ski patrol, you're, an EMT on the back of an ambulance, get someone to come to the hospital, or you're the neighbor, family member, whatever the case, and you're refusing. So if someone is really acting out and especially aggressively, or you just don't feel that they are in a mental state where they can actually make a decision, then there's also the whole piece of potentially protective custody. And many states will do that, where you can call in the police, they can put them in temporary protective custody and get them looked at in the hospital. And I know that we did that in Delaware. If we had someone who, was, in fact, I had a family member who was in that situation because of a case of encephalitis. and his wife had called me, and he was refusing the paramedic care, and I had a chance to chat with our emergency physician before the call came in on the base station radio, and no, I mean, like, you're gonna haul him in, or we're gonna call the police, and and now it's my family members, like, we're gonna rope and hog tie you, and we're gonna get you in there. So thankfully he came in and we were able to treat him. Okay, whatever. Documentation is really important. So whether you're doing this in your role as a patroller or an EMS, or I would actually advise that even if you're in that neighbor role, that at least jot a few things down on a piece of paper that you can keep. Not that anybody, hopefully, in your neighborhood is going to come back after you, but at least you have the details of what you did and the decision making. I always think it's important to document these things so that you remember if there's ever a point in any case where you have to then tell someone, what happened and what you advised. So myth or fact, do you have to prevent a patient who has a head injury from falling asleep?
Anyone?
Fact.
Pardon me? We have a brave person says fact.
You got a couple of that same myth in the chat.
Okay.
I would say no. You don't know.
You have some no's. Okay. All right. Well, so there's like a fine line here, right? So the idea is you don't actually have to prevent them from going to sleep, but you have to be able to wake them up. So usually when you're discharged with a head injury and a period of observation at home, you're going home with a responsible individual. They will ask the responsible individual to wake the person up about every hour, just to make sure that you can. Now, that also means keeping an eye on somebody to make sure, their breathing hasn't changed. Literally, there truly is a period of observation. It's not like the guy puts you to bed and goes to bed and then sees what happens at 6 o'clock the next morning.
The patient is allowed to go to sleep, but you're not.
Right. Usually that's kind of the rule of thumb there. And we had that situation actually with Larry's father on a ski trip to Stowe, Vermont, where he did a header in front of a Wendy's with dock sides on and icy sidewalk. So yes, we spent one night at Stowe doing that. So the next day skiing, we were a little tired, but anyway, okay. So when am I most concerned? And there are certain situations that worry me when I'm taking care of somebody. This is in the aid room when they come in with a head injury. So if the person has no memory of the event or the incident, immediately that's basically a retrograde amnesia, right? So that is sort of our indication there may have been a loss of consciousness. So no memory in my mind equals loss of consciousness until proven otherwise. It's a problem. A witness loss of consciousness. Okay, they've had enough of a hit to be knocked out. That's a big deal. If they are perseverating or they are very confused, when they have intoxicants on board, it's very challenging. We're not going to be able to figure that out. What we can't do is assume that it's all due to alcohol intoxication and sort of let them go sleep it off. There's actually a situation in emergency departments in the United States many years ago, where the way that they would treat patients who are the drunks would be put them on a stretcher, put them in a corner, and let them sleep it off. And then there were several of these people that made the news and case reports where they never woke up because they died because they also had a head injury, right? Alcohol also acts as an antiplatelet agent. Alcohol prevents platelet aggregation. So if somebody's drunk and they fall down and hit their head, they are much more likely to bleed more. People who say they're dizzy, they probably took a hit to the back of their head. There may be something going on in the cerebellum. I mean, it may clear. It may be just post-concussion dizziness, but we don't know that. Any change in Glasgow Coma Score, sensory or motor changes, even if they're subtle. That again warrants concern and a need for a physician or advanced practice provider evaluation. Headache and visual changes. Keep in mind the visual cortex is back in the occipital area of the brain. Neck pain, midline tenderness worries me. Midline tenderness is an indication of a spine injury and potentially cord injury. Anticoagulant use and advanced age, again, because there's more room in the head and more minor trauma can produce a bleed, and you don't see the signs and symptoms of that right away, but it can develop over time. What worries me most, there's a lot of things that worry me a lot, but if the person drove themselves to the ski area and they've got little kids or they've got other people in their vehicle, the father with little kids, like there isn't a driver there that can drive them home. That I'm really worried about. That's when I call the spouse or I call somebody or I try to get them to be seen in the emergency department. So the question is, are you prepared?
Again, think about the causes of head injury. We have sports, we have motor vehicle crashes, we have falls, the elderly. You know, are you prepared to deal with these patients and assess them properly and assess them well and be prepared to motivate them to seek further care?
These are not like one size fits all cases, right? So the person who's of advanced age is a very different type of situation than the younger person. Physiologically, they're different. And so your approach sort of changes based on that. So the picture to the right is Merlin. He's our ski patrol cat. Our cat. Actually, I wound up making him. So what questions do you have? We have about 5 minutes left and would love to have any questions that you may want to shout out.
Looks like Dave put something in the comment about an acute concussion evaluation.
And a concussion evaluation, okay. Oh, so this is one of the sports-related concussion evaluations. Is that right?
Using a brain line in a pre-hospital
Says
setting?
yes.
Okay. These certainly can be helpful. The only problem is that sometimes concussion, it may not just be a concussion, it may be also some underlying bleeding, and we're not necessarily know that. So these tests, though, can show that there may be some deficits, and those deficits will at least be sort of the impetus for us to say you need further evaluation.
Mm-hmm.
And I think that may be how you use it.
Yeah, if you've been properly trained in using them, I mean, you know, we have physical therapists and higher level providers that may have been trained in something like that, and they're probably excellent tools for the information they give us, but using it definitively for patient care, I think we'd have to be careful with.
Yeah. I mean, we can say, oh, they have a concussion, but we can't say
that they don't.
That they don't, or they don't have an underlying bleed or other problem.
Right.
I think that's the challenge. But thank you for that.
Do we have any other questions, comments, or concerns?
Any scenarios that you all would like to share that were
cases you've had?
Mr. Snyder, my question is the one that scares me the most, what I call the catch and release, where we have them, we have to make a determination, is this an EMS transport or can they safely seek medical attention on their own? They usually use the description, I rung my bell, and we usually have them for 20 minutes, before they get released or they have to make a decision. But those are the ones where they're on that bubble. Do you have any suggestions other than recommending medical care and documenting it that we should be, is there anything as such as a weak concussion that we shouldn't be too overly concerned about?
So I would go through and do a very good neuro assessment to see if there are any abnormalities that you're coming up with. If there's nothing that is jumping out at you, but they still kind of feel like that, again, their bell's been rung, but there's just nothing that would make you say, I'm going to call 911, right? You want to have them be with someone who is a responsible adult partner, somebody who can watch them. Ideally, they shouldn't be driving. If there's someone else in their party, they can drive them home. And I would always document in whatever charting system I'm using, whether it's in an EMS system or a hospital or our run forms, right, for ski patrol. I'm always documenting that I have advised medical attention and you're to seek medical care. And then especially if the symptoms, worsen or persist, that information should be in all of our charting.
We've had a couple of those cases recently, and thankfully, they've all had competent drivers. So we've tried to have the convincing conversation with them, given them all the reasons they need to go to the hospital, preferably in an ambulance, and they've refused repeatedly. And we try to give them, that convincing conversation, and we give them those warning signs about if you have, visual disturbances, nausea, vomiting, headache increasing, give them all those head injury signs and give it to the driver, give it to the rest of the adults in the group, and just say, look, if any of these happen, you go to the nearest emergency room.
Or call 911 and be met somewhere by, an EMS unit. So
I mean, people they have autonomy, and it's very difficult to get some of these folks, and inevitably they're leaving the Poconos and they need to go to northern Jersey.
I had a gentleman who, again, he had children with him, and he was the only driver. And I wasn't liking what I was seeing because he had some subtle neurodeficits. So I wound up calling his wife, and she said, no, you're going in an ambulance, and I'm coming up, and I'm going to pick up the kids. And fortunately, she didn't live that far away, and she was able to do that. And he came back a week or two later, and he said, I'm glad that you did that, because he had a small subdural hematoma. So it's not that uncommon. I mean, we have to, again, to be safe, I sometimes think that, what is the worst thing it could be? And at least direct your care in that way. You're not trying to send everybody out in an ambulance. That's not what I'm advising here. But it's just to be careful with this. Try to have that convincing conversation. At least have them be transported by somebody within their group. Or if they can't, who can you call to have that convincing conversation, right?
And document.
Yeah.
Sometimes the hardest ones to convince to go are the young ones, because they think they're impenetrable, so to speak. And they're with their buddies, and it's like, I don't want to look like a cis, that type of thing. But you really have to be hard on them and sometimes you have to get a hold of the parents.
Mm-hmm.
Is there anyone who has had a particularly successful technique in convincing people who have had injuries to go and be seen that they'd like to share?
Today, I discussed like the NFL concussion protocol that like a lot of football fans will have been familiar with a patient who had one, and he seemed to be amenable to that, even though I told him every 5 minutes the same thing until the ambulance showed up.
Awesome.
Well, I was going to say, one of the problems, and it's not just with head injuries, is when you have especially the young adult who says, there's no way I can pay for an ambulance.
Mm-hmm.
Yeah.
I don't have insurance. and they're just not going to do it.
Yeah.
You know, so you can give them whatever advice you have, document, but you know, they're between a rock and a hard place also.
Yep. Yep. We've seen those.
Many times, it's documentation but still try.
Sure.
At the end of the day, emergency departments cannot turn you away if you don't have insurance. And
You just have to get there yourself.
Yeah. And a follow-up to Richard's comment about young people being the hardest to convince. The next hardest group of people to convince are some of our own patrollers occasionally.
yeah,
True.
probably all known of those incidences over the years if you've been doing this long enough. So, well,
Right.
we can't, unless there's something else, we can't thank you enough for hanging in here with us, and pardon the mosquito and all of that that may have been distracting, because it was certainly distracting us. We appreciate the time, and hopefully this helped in understanding that injury.
Yeah.
Yep.
Thank you again, everybody, for coming out. Well, coming on here. I sent out